Welcome to Season 4, Episode 5 of the 6 Lessons podcast. Today our topic is fiber in restorative dentistry. When did this start? Well, it actually started with a periodontal application of a fiber called ribbon that's woven, and that polyethylene fiber was useful to stabilize anterior teeth that were periodontally compromised and they were loose. And so that looseness was mitigated or stabilized with this bonded fiber, and that's what it was invented for. Dave Rudo and his company made that, promoted it, but then he gave it to a friend of his named Ray Bertolotti, and Ray Bertolotti gave it to a friend of his named Sema Belli, and Sema Belli was working with a graduate student on a PhD in Turkey and in Japan. And she said, what would happen if we put this fiber inside a restoration? She was thinking outside of the box, but it was going to help us in the box, which is restorative dentistry and the high C-factor stresses that are there. This all happened around the year 2000. 2001, Sema Belli and Inokoshi published an important paper on resin coating, and then 5 years later, she was able to publish a paper on restorative dentistry with ribbon inside as a liner. And what the liner did with ribbon is that it changed the stress on the hybrid layer. And this paper was published in 2006. She published a follow-up paper in 2007 comparing ribbon, which is the polyethylene fiber, with Everstick net, which is a glass fiber. Then she had some similar results of stress reduction to the hybrid layer, meaning maximization of the hybrid layer underneath the fiber that was placed, and the fiber was underneath the restorative composite. What happened? Well, what happened is that the seal in these preparation that had the fiber was superior to the seal of a composite in a class 2 restoration or a class 1 restoration, because the fiber allowed a movement of the composite shrinkage in two directions. If you put composite against, here's your cavity wall, and you put composite, then you would like it to shrink towards the cavity wall, but the bulk of the composite means that it will shrink towards the enamel and lift off of the bottom of your box. So the composite moves like this because the enamel attracts the polymerization of the composite more quickly. So that is a problem because you get leakage at the bottom of your box. But when you put fiber on this wall, what happens? This area down here stays sealed. And that's because the movement of the composite is not putting stress here. It's actually able to move towards the surface of the tooth underneath the fiber. Now, the ribbon did it a little bit better than the Everstick net, but the principle was the same. The ribbon was able to separate a little bit, and the Everstick net was able to separate a little bit, but there was bond to the wall of the tooth, and there was bond to the bulk of composite, but there's less bond as the fibers separated. And there were follow-up articles by Osel in 2007, El Moafi in 2007, and then the final one was Erkut in 2008, which was scanning electron microscopy actually showed that mechanism. And so people talk about fiber reinforced composite. I don't like that, although it does carry some valid scientific ideas. After ribbon was used for periodontal splinting, there was this time when a group in Holland used the fiber to see if it could stop any fracture into the tooth. That's a very important thing, fracture resistance. And so that group out of Holland at Nijmegen University with Kuijs and his associates, Fennis, Willem Fennis, they were able to show that you can stop cracks with the fiber. And so actually in the 6 lessons approach, we used that concept that was published in 2000 and 4, 2005, to teach a fracture resistance or a fail-safe. If you had a fracture of your onlay, you would like it to stop before it gets to tooth structure. So that's called a secure bond or a fail-safe mechanism in the restoration. So we actually taught that in 2004, 2005 before the paper on the stress distribution or the stress relief was published by Belli in 2006. So fibers can do two things. They can stop cracks or they can stress relief by allowing the shrinkage of composite to move in multiple directions instead of towards the center of the bulk of composite, which will always cause a peeling at the edges of a restoration. There's several concepts there, but basically the world's expert in understanding these, I'm one of them, but Mark Frater, a good associate of mine, we've published several papers together at Szeged University. Mark Frater is the world's experts on both the Everstick materials and Rib-On materials, and we've published a paper comparing using one only or both together, and we've come to the conclusion that Everstick is a little bit better on fracture resistance, but it's not as good on stress relief, and Rib-On is good on both. If I only had one fiber, I definitely would use Rib-On, but the fibers of the glass fibers that are silanated, they have a little bit more bondability to the composites, where Rib-On doesn't bond to composite because it has no methacrylate bonds that can be polymerized in a free radical polymerization reaction. But the fiber as a stress reliever is the most important concept in composite rather than a reinforcement. So I don't like to use the term fiber reinforced composites. So continuing our discussion of fibers, Simone Della Peri and I published a very important paper in 2017, and it was entitled The Wallpapering Technique. That came from Wendell Robertson, one of our very creative partners in the biomimetic teaching at the 6 lessons. But the idea of a wallpaper is that if you place the fiber on a cavity wall, an axial wall or a pulpal floor, if it was pulpal floor, I guess it'd be carpeting rather than wallpapering. But if you place that fiber in these areas next to the pulp's here, your axial wall's here, your pulpal floor's here, those are the areas you want to protect from leakage and from infection. And so that wallpapering technique on vital teeth is for pulp health. But a wallpapering technique on a non-vital tooth, obviously the pulp is gone, but we want to conserve the coronal tooth structure for as long as possible. The weak link in an endodontically treated tooth is the root that cannot be strengthened or even biomimetically restored because the root of an endodontically treated tooth now changes from a more tough material to a more brittle material without the hydration of the pulp. But the coronal portion of the tooth can be reconstructed in a way that has not failed. If we've ever had a failure in an endodontically treated tooth where we're using Rib-On as part of the reconstruction, it's always been in the root. The root has fractured. Doesn't happen that often, but it can happen. So our first goal in a biomimetic approach is to prevent endo. But once we've had the endo, is it worth the effort to save the tooth and not have it extracted, thinking that an implant might be the next best option? Over the last 25 years, we've been able to conclude that implants are not the best next option because implants have a failure rate that can be up to 15, 17%, depending on who you talk to. And implants are quite expensive, so if you have even a 10% failure, you would feel like the patient's at risk of having to do some more expensive dentistry if this is one of the 10% of the implants that are going to fail in the next 10 years. And so now that we've been doing reconstructions biomimedically with the 6 lessons for over 25 years and with fiber since 2006, so that's 20 years. So for 20 years, we've been able to say, what's our failure rate? And it's nowhere near 10% in 10 years. And so I've had 2 failures. Davey's had 1 failure. Simone's had 1 failure. Davey's had 2. Simone's had 1 that I know of. So that's 5 in 3 full-time dental practices in a biomimetic approach. And so a patient, if they're given the option in our office, and I try to be, as I say, implants are good if you've lost a tooth. But if you have a tooth that's going to be extracted because a doctor can't figure out how to fix it, well, we've figured out how to fix it, and we've taught hundreds of dentists to fix them around the world. And the feedback we get is that this is preferred over implants. Our best example of that is Dr. Andras Forster in Budapest, Hungary. He worked for 5 years in the most exclusive implant clinic in the world, the Urban Clinic, and Dr. Urban is a internationally expert in implants, but he also restores teeth in his office. And Dr. Forster was the dentist in charge of the treatment plans to say this tooth is restorable or this tooth is non-restorable. After he learned the 6 lessons, this is 6 years ago, every year they did more and more restorative on teeth and less extraction of teeth. Now that's important clinical data that you won't learn anywhere else. But we have that because we have masters who are associated with experts in implants. But we have masters who, because they can use fiber in this wallpapering technique that Simone and I have written about on an endodontically treated molar that is now over 15 years successful, we can show that the fiber reconstruction, I almost said fiber reinforcement, but I'm trying to get away from that term that has been used kind of loosely, but the fiber placement in this restored molar that Simone and I published had 2 purposes. The first purpose was make sure that the hybrid layer next to the dentin is as strong as possible. And then on the enamel, we have the idea of placing the ribbon close to the enamel, but we keep it still out of the peripheral seal zone. And all of a sudden, we have the best of both worlds. We have a tooth that if you had fracture in the coronal portion, you would have a crack in the enamel. Well, this is very biomimetic. It's like a tooth. A tooth can have a crack in enamel and not allow bacteria to go into the pulp. The crack stops at the DEJ. Ribond does the same thing. Everex Posterior does the same thing. But in this wallpapering technique now, the ribond becomes the DEJ mimicking aspect of the restoration. The DEJ that has 2 materials, enamel and dentin, coming together very strongly. Now we have ribbon allowing enamel replacing materials and dentin replacing materials to come together very strongly. But if we have a wallpapering of all the walls of an endodontically treated molar, for example, it's kind of like a basket. So we call this a ribbon basket. Wallpapering and ribbon basket, we use those phrases interchangeably in the 6 lessons approach. But these baskets of ribbon that are next to the walls now can be filled with layers of Everex Posterior or Everex Flow, because the fracture resistance inside is good. It's just not so good because it shrinks too much. But if it shrinks inside a ribbon basket, the ribbon takes care of that shrinkage stress by deforming a little bit. And so that idea of having ribbon on the outside of your core buildup done with Everex Posterior, we've never had a reported failure in those coronal portions of a tooth that's reconstructed with the fibers, both with ribbon and with Everex Posterior. So fracture resistance on Everex materials, a little better. The stress relief, which is the most critical part of a biomimetic restoration, is superior with ribbon. So to summarize, a vital tooth is our goal, and the vital tooth is always restored the best with ribbon. If the tooth has died, the pulp has died, the reconstruction with the ribbon is still the best if you don't have an option to have a combination of ribbon and the Everex material. Everex material inside of ribbon is something that we use on a regular basis. In a vital tooth, you may have a very deep cavity that you might want to use that technique, a very wide cavity where you wallpaper the walls and then fill that with ribbon. But again, this is where your sophistication and your training in biomimetic dentistry will be very valuable, because you'll have a framework to understand what are you trying to accomplish. And we usually say the 6 lessons approach is a bottom to top approach. We have a hierarchy of bondability, and the hierarchy means the bottom of the restoration is the most important. Caries removal, crack removal, mimicking the DEJ with immediate dentin sealing, resin coating, mimicking the dentin with deep margin elevation, and then enamel replacement, onlay design, and then occlusion. And so we teach the most important aspects first: caries removal, crack removal, gap diagnosis, immediate dentin sealing, hybrid layer formation, and then your dentin replacement has to be stress reduced so that you don't compromise your hybrid layer. And so if you have a bottom to top approach, that's the best way to think about restoring a tooth. Till next time, stay bonded.